The next thing I'll be talking about is eustachian tube dysfunction. This is something probably is the most common thing that I see in my practice. It's maybe not the most exciting thing, but it frustrates a lot of patients, especially when it becomes chronic. And so I think it's important to kind of give you guys a spiel about that and what we kind of try to do for them. So I'll talk about the anatomy and the function of the eustachian tube, the pathophysiology of eustachian tube dysfunction, potential causes of eustachian tube dysfunction, what we do in terms of clinical evaluation and diagnosis. And then importantly, I think we'll talk about the differential diagnosis. I think there's a few things that can kind of mimic eustachian tube dysfunction, and so it's important to ask the right questions to rule that out. And then we'll talk about the treatment of eustachian tube dysfunction, and then we'll talk about an entity that I think is a little bit underdiagnosed, which is patulous eustachian tube. So the eustachian tube is a funnel-shaped tube connecting the middle ear to the nasopharynx. So this is the eustachian tube here. It passes superiorly, posteriorly, and laterally from the nasopharynx up into the middle ear. The adult eustachian tube is 36 to 38 millimeters. Children tend to have a shorter and more horizontal eustachian tube, so it'll kind of go in this direction. And they're more floppy. And because it's horizontal and shorter, that's why children, they tend to have more backup of fluid and more infections and more pressure. So the lateral part of the eustachian tube, the lateral 1/3, this area is bony, and then the medial 2/3 of it is cartilaginous. And the junction between the cartilaginous and bony portion is called the isthmus, which is the narrowest part. And so this cartilaginous portion is the only part that's dynamic, so it opens and closes. And there's 4 muscles that kind of attach to the cartilaginous portion, the most important of which is the tensor veli palatini, which is this one. So the 3 main roles of the eustachian tube: equalization of pressure within the middle ear. It protects the middle ear from infection and reflux, and it clears out natural middle ear secretions. And all 3 of these functions are mediated by the opening and closing of the cartilaginous portion of the eustachian tube. So the eustachian tube is usually at rest. At rest, it's closed, and then it opens with things like swallowing or yawning or the Valsalva maneuver. And like I mentioned, the tensor veli palatini, which is this muscle here, is the main dilator of the eustachian tube. So when this contracts, it causes the eustachian tube to open and that pressure to equalize and that fluid to be released. And this is just an anatomic view of that in the nasopharynx. So this is the tensor veli palatini kind of contracting and opening up the eustachian tube, which is this is the opening of it there. So pathophysiology of eustachian tube dysfunction, first of all, it's pressure dysregulation. Negative pressure is continually accumulating in the middle ear due to natural absorption of middle ear gases. But if the eustachian tube cannot open to ventilate adequately, negative pressure will build up in the middle ear. So patients will feel this pressure or fullness, pain, hearing loss. They can have some crackling sounds as they try to open up their eustachian tube. The other part of the pathophysiology is an impaired protective function. So if there's reflux into the eustachian tube, you can get nasopharyngeal pathogens, allergens, gastric secretions into the eustachian tube that can cause inflammation. And like I mentioned, it's more common in children due to their short and floppy eustachian tubes. So causes, the most common causes of eustachian tube are inflammation related. So allergies being the most common reason in that category. There's definitely infections that can cause eustachian tube dysfunctions, whether it's adenoiditis, nasopharyngitis, or sinusitis. When acid reflux or laryngopharyngeal reflux is really severe, it can also come up into the nasopharynx and cause eustachian tube dysfunction. Hormonal changes in pregnancy, especially in the 3rd trimester, sometimes we see with those hormonal changes, patients will have swelling of their eustachian tube. Other etiologies, sudden changes in pressure, we call this ear barotrauma, quick descent from air travel, scuba diving, those things can cause eustachian tube dysfunction, especially if the patient already has some pre-existing allergies or they're flying with a sinus infection, they're going to have some issues with this. Then there's also acquired anatomic abnormalities. These are a little bit less common, but you can get nasopharyngeal masses like nasopharyngeal carcinomas, which are rare in the population we treat. But really, technically, in any adult with a unilateral middle ear effusion, we should be probably scoping them and taking a look at their nasopharynx to make sure they don't have any mass in that area. Cleft palate is a very common reason to have eustachian tube dysfunction. In these patients, their tensor veli palatini is not as well developed and does not have the normal midline insertion into the palate, and so it can't contract to open up the eustachian tube as effectively. So cleft palate kids are so prone to middle ear infections and effusions that we almost universally put tubes in them when they're getting their cleft lip or palate repaired. And then adenoid hypertrophy, which is something that we see commonly in kids. So when we see these patients, history is the most important to try to decipher what they're experiencing and what the diagnosis is, I think. So the most common symptoms that patients will complain about is ear fullness or pressure. They say their ear feels plugged up. They want to pop their ear, but they can't. Those are like the words that I'm looking for when they come in. Some patients will have some ear pain. They'll have some subjective hearing loss. Sometimes they'll even have tinnitus on that side, and this can include not only just high tone or high pitches, but also popping and crackling sounds that they hear. In more severe cases, they might be a little off balance. They might get some vertigo. I'll ask them about recent air travel or scuba diving. Allergy symptoms, sneezing, rhinorrhea, sinusitis symptoms, and symptoms of acid reflux are also important to ask about. So on physical examination, this is a normal tympanic membrane. You have the malleus here that you can see, but in eustachian tube dysfunction, sometimes what you'll see is a retraction of the tympanic membrane, where the tympanic membrane is kind of sunken inward, and sometimes you'll see this short process of the malleus kind of bulging forward. That can be an indication of eustachian tube dysfunction. Sometimes we'll see middle ear effusions, especially more severe cases of eustachian tube dysfunction. And that's what you see in this picture here with these little bubbles, a mucoid effusion behind the tympanic membrane. But I will say, a normal otoscopic exam doesn't necessarily mean the patient doesn't have eustachian tube dysfunction. I would say in the majority of patients that I see with eustachian tube dysfunction, their eardrum kind of looks pretty normal. If it's available, I think pneumatic otoscopy is important. A normal drum will move inward with positive pressure when you're pressing on the bulb, and then outward with negative pressure as you're releasing it. In a fluid-filled middle ear, there's going to be limited movement. The eardrum's not going to move much at all because it's restricted by that fluid. When the eardrum is retracted, what you'll actually see is more movement outward with the negative pressure. As you're releasing the pneumatic, the little bulb, the eardrum will kind of pop out to you more. And a tuning fork exam, I think, is important if you have it available to you, and we'll talk about that in a second. Audiometric evaluation, this is something that we have available in our office, which is great to have. And so I think a tympanometry is really important. This measures the compliance of the eardrum when pressure is applied to the external ear canal. It's kind of an indirect measure of the middle ear pressure. So a normal eardrum will have a kind of a nice little tympanogram that looks like this with a nice peak, but sometimes you'll get a flat tympanogram, which is a type B tympanogram, where it's kind of just flat, the eardrum doesn't move at all, and that's a sign of a middle ear effusion, or it can be a sign of a perforation. And then type C is when there's a negative pressure, and that's what we see with eustachian tube dysfunction. We'll also get pure tone averages when we do our hearing tests, and what you'll see, sometimes you'll see a mild to moderate conductive hearing loss, and that's usually in very severe eustachian tube dysfunction, or definitely if they have a middle ear effusion. But oftentimes the pure tone averages will be normal with patients with eustachian tube dysfunction. Just going over the differential diagnosis, I think there are a few things that can mimic eustachian tube dysfunction. I think probably the most common thing is TMJ disorder. These patients, especially who grind their teeth and clench their jaw and they don't wear a night guard, they can get these ear blockage symptoms that are often misdiagnosed as eustachian tube dysfunction. They'll get kind of a deep ear pain, a pressure in their ear. Sometimes they'll have some preauricular tenderness and pain. Sometimes you'll even feel some crepitus or over the TMJ joint. So I think it's important to ask these patients about a history of grinding or clenching at night because, like I said, it can very much mimic eustachian tube dysfunction. Another thing is sudden hearing loss, sudden sensorineural hearing loss. Especially, if you have a patient with unilateral eustachian tube dysfunction, or it seems like it's that, this is something to try to figure out rule it out. So they can often present with unilateral ear fullness and tinnitus on one side. Typically, their main complaint is hearing loss. So if hearing loss is the main complaint, I think definitely think of sudden hearing loss. Whereas if it's mostly this pressure or fullness, that might be most likely eustachian tube dysfunction. But this is where a tuning fork exam, I think, is important if you have one in your office. And what I typically do, especially if it's unilateral, is I'll do the Weber exam, where you put the tuning fork either on their forehead, sometimes you can put it on their top front teeth. And in eustachian tube dysfunction, the sound will be heard either in the middle or it'll lateralize to the ear that's affected. Whereas in sudden sensory neural hearing loss, the patient will hear the sound louder on the opposite side. And so if they're hearing the sound on the opposite side, it might be an indication that they have sudden sensory neural hearing loss. And that might be a good reason to send them to us urgently so we can do a hearing test and kind of confirm that. Because sudden sensory neural hearing loss needs to be treated as soon as possible with oral steroids. Another thing that can cause some ear fullness is Meniere's disease, and ear fullness is or pressure is one of the four main symptoms of Meniere's disease. But they also have hearing loss that's usually low frequency and sensory neural in nature. They'll have tinnitus on that side, and then typically they'll have some imbalance or vertigo. And then finally, patulous eustachian tube, which I'll talk about at the end, but they can also have some ear blockage or fullness symptoms. I think the differentiating thing is this symptom called autophony. So in terms of the treatment of eustachian tube dysfunction, randomized trials for this condition are limited, and study outcomes vary widely between studies. Definitely, the treatment should be directed at the underlying etiology if it is known. So if the patient has sinusitis, allergies, or LPR, treat that appropriately, because that might solve the condition. But if the etiology is unclear, consider a referral for an audiogram to rule out other issues. There's not much evidence to support pharmacologic therapy for isolated eustachian tube dysfunction without any cause. But I would tell you most patients will have some allergy component that they have. So because of that, our treatment is kind of geared mostly towards allergies, especially if they don't have symptoms of sinusitis or LPR. So my basic regimen is for the patient to start Flonase once a day, Afrin twice a day, but only for 3 days, just to avoid that rebound congestion, and then Sudafed, and I like the Sudafed that you have to ask the pharmacist for. So the 12-hour, 1 to 2 times daily, as long as they don't have any heart problems, cardiac issues, or blood pressure issues. Oral steroids are always a question. I think, again, they've shown some benefit in animal models, but this hasn't been realized in human studies. I do use them, especially in patients who have already tried the above 3 things that I mentioned. Kind of as a last resort from a medical management standpoint, I will offer them like a Medrol dose pack. I do think autoinsufflation is okay for them to do, occasionally throughout the day, as long as they don't have a middle ear effusion. Patients often come in, with eustachian tube dysfunction, and they're going on a flight or they're scuba diving. I think ideally they can put that off, but I do think it's safe to fly if it's just eustachian tube dysfunction and they don't have any middle ear effusion. I do tell them to take a Sudafed and spray Afrin in their nose before takeoff. I also tell them to spray Afrin in their nose on descent. And then I ask them to start Flonase at least a week before the flight if possible. Earplanes are these, I don't think there's any, or I haven't found any research that actually supports this, but they're these little earplugs that you can wear in your ear, and they have a filter in them that slows the shift of air pressure that enters your ear canal. And I think, these are low risk, and anecdotally, a lot of patients say that they seem to be helpful. So I also mention that to patients who are flying soon. But yeah, if the medical management fails, then we have more interventional options. The most common thing that we offer is a myringotomy with or without tube. And in this procedure, the pressure is equalized through the tympanostomy tube rather than the eustachian tube. So it's kind of like a Band-Aid for the issue. If the tubal pathology persists, and the eustachian tube symptoms will likely recur once either the tube falls out or the hole heals up. And you always have to warn patients that there is a small risk of a permanent perforation when we do this procedure. More recently, there's another procedure that's become available called Eustachian tube balloon dilation. In this procedure, basically what we do is we take a balloon catheter and we thread it, it goes through the nose, we guide it endoscopically, and we thread it into the Eustachian tube, and then we blow up the balloon for a couple minutes, and then we take it out. And the hope is that it kind of keeps the Eustachian tube dilated and allows that pressure to be equalized more effectively. I said it usually requires general anesthesia, but I will say more and more now it's being done under local anesthesia. I don't know if this is. Let's see. This is just a quick video of it, if it plays. Let's see. Yeah, this is just a quick video. This is the balloon going down the nasal cavity, and we make a little turn into the nasopharynx, into the Eustachian tube, and we basically thread the balloon catheter in there, and then the balloon is inflated for a couple minutes like that, and then it's taken out. And that's the whole procedure. It's pretty quick. And there is some data to support it. There's a randomized trial of 60 adult patients with chronic Eustachian tube dysfunction, and in one group they gave them medical therapy alone, which was just nasal steroids, and in the second group they did balloon dilation plus medical therapy. And what they found in this study was that the Eustachian tube symptom scores improved significantly more at 6 weeks in the balloon dilation group compared to the control group. In addition, the patients that had abnormal tympanograms at baseline, whether it was type B or type C, 57% of them showed normalization in the balloon dilation group and only 10% in the control arm, and that was statistically significant. And they did have a follow-up study that showed that results were sustained at 52 weeks as well. So the results are overall good. I usually tell my patients, if we're going to go down this route, I like to set the expectations good, and so I usually say maybe 60 to 70% chance that it'll give you some benefit. So the last part of the talk, I just want to talk about an entirely different condition called patulous Eustachian tube, which is essentially the opposite of Eustachian tube dysfunction. Eustachian tube dysfunction is when the Eustachian tube is kind of inflamed and narrow and shut off, and patulous Eustachian tube is a chronic patency of the Eustachian tube where it's too open. So again, the symptoms, they can be similar in that they'll complain of this plugged, full sensation in their ear, but the differentiating thing that I see is autophony, which basically means they kind of hear the echo of their own voice in their ear. They kind of hear this resonance of their own voice in the ear, or they'll hear their own breathing in their ear. A lot of times symptoms are improved when the head is in a dependent position, like when they're lying down or when they have an upper respiratory infection, just because that causes more edema within the Eustachian tube and kind of fixes this condition in a way. And it may worsen with exercise or prolonged speaking. Both of these things can dehydrate the mucosa, and then there's a decongestive effect from the epinephrine-like hormones released with exercise. So sometimes I'll ask them, is it worse when you're exercising? A lot of them will say, yeah, I feel it only at the gym when I'm working out or when I'm running. Similar things can cause patulous Eustachian tube. Allergies, especially chronic allergies, can cause mucosal and submucosal atrophy within the Eustachian tube. Very quick weight loss can lead to tissue atrophy within the Eustachian tube. Reflux can also similarly cause some mucosal atrophy, like I mentioned, dehydration, neuromuscular disorders, any decongestant use, intranasal cocaine use, Afrin overuse can cause that Eustachian tube to become too open. So the treatment, this is a relatively rare condition, so there isn't that much research. So there isn't that much research there, but first thing we usually try is just hydrating the mucosa with saline. Obviously, if they're really underweight, try to get them to gain weight. But then there's certain drops, and one of them is the estrogen drops, and then the other one is the patulin drops. And what these do is basically they induce inflammation within the Eustachian tube. So a lot of times when they're putting these drops into their nose, they'll actually feel like this burning sensation in their nose as it kind of travels back, and then they'll sometimes even feel a little burning in their ear. And I usually tell them that just means it's working. There's even surgical management for this, especially when it becomes chronic and is unresponsive to that medical therapy. For whatever reason, tympanostomy tube placement, which seems counterintuitive, can be beneficial in about 50% of patients. But typically what we're doing is some type of direct therapy to the eustachian tube orifice here. Some people will place a catheter filled with bone wax into the eustachian tube to partially obstruct the eustachian tube. And then there's certain injections that we can do kind of around the eustachian tube orifice. Sometimes it's gel foam, filler, autologous fat injection around this area to kind of bulk up that area and close off the eustachian tube. So in conclusion, the eustachian tube helps to equalize pressure between the middle ear and atmosphere, and it also protects the middle ear from infection and reflux. Inflammation and anotopic obstruction of eustachian tube are the main causes. Common symptoms: ear fullness, I want to pop my ear but I can't, hearing loss, pain, tinnitus. On physical exam, you might see a normal eardrum, you might see a retracted eardrum, pneumatic otoscopy if it's available, and again, if it's unilateral, I definitely think a tuning fork exam would be important. An audiogram with tympanometry if it's available to you. Obviously, you can send them to us for that. We have that available on every day. And then the treatment, treat the cause if it's known, but otherwise it's Flonase, Afrin for 3 days, Sudafed, and I do think an antihistamine is reasonable if they do have symptoms of allergies. And if that fails, you have a laryngotomy with or without tube, and then the newer procedure of eustachian tube balloon dilation. And I think, just to reiterate, just be aware of patulous eustachian tube. I usually do ask my patients whether they hear the echo of their own voice in their ear, breathing in their own ear, and if they look at me funny, then I usually know that they don't know what that means. But if they really resonate with that, then I'm like, okay, maybe we're treating the wrong thing here. Okay, that's it. Thank you. Any questions with that one?
Do you feel like for patients with ear fullness with a normal tympanogram?
Yeah.
Do you feel like the procedure, eustachian tube dilation, is as effective compared to those patients who have a retracted TM or an effusion?
Yeah, definitely. If they have a normal tympanogram, I probably wouldn't take them for eustachian tube dilation because I think the patients that have an abnormal tympanogram, they definitely have better results. And if the tympanogram is normal, I'm very hesitant to do any procedure. And I really like to rule out those other causes that we mentioned, especially TMJ disorder.
That was excellent. Being that you're now in your first decade of practice, and some of the senior people, we have dealt with this problem, and now there is a solution. I used to have a cadre of patients. I'd be putting tubes in, T-tubes in, and now with the eustachian tube dilation, we're able actually, it's almost like a scar contracture of the eustachian tube, and then that opens it, and those patients can be offered, their next set of tubes when they fall out, ET tube dilation and then a myrigotomy. So I've had a great success with this procedure, and those patients are really happy after this procedure. So it's a new innovative option for those people. So great, thank you.
Thank you.